Good afternoon. I'd like to acknowledge here the members of our adult immunization work group. I'd like to thank my colleagues, my other ACIP members, as well as our ex officio members, our CDC lead, as well as liaison representatives and consultants. And I definitely want to make sure that we thank, in particular, Carolyn Bridges, who, as many of you heard, we had certain people who were trying to keep us moving forward. And in that vein, also would like to thank Jean Smith and everyone else who was here helping us to move forward. So if we talk about the adult immunization schedule, very much like the child immunization schedule, we update this annually. And it is also to reflect and summarize existing ACIP policy, so we won't be necessarily talking about any new policies. We do this through a series of minimally monthly meetings of the work group and consultation with vaccine subject matter experts. And as you can see, there are many nuances and very specific issues that often have to be addressed. We will update and approve policy changes up until this meeting, so at the October ACIP meeting, if they're published in the MMWR prior to the publication of our adult schedule, which we anticipate to be early 2014. We also work collaboratively with many of our colleague organizations, which include the American College of Physicians, the American Academy of Family Physicians, the American College of Obstetrics and Gynecologists, as well as the American College of Nurse Midwives. And so they actually approve our schedule. Like the childhood schedule, we're actually going to present the work group evaluations with our specific footnotes and table changes, and then we'll follow with a discussion and vote. So I'd now like to call our CDC lead, Dr. Bridges.
Thank you very much. I'm going to be summarizing the changes and updates for this year, and I'll start with the figure. So the updates to the figure include really just two changes. One, so that as a reminder to providers for patients who are seeing patients who need both, the PPSV 23 and the PCV 13, we moved the order of those bars. So now PCV 13 is first. And based on the new Hib vaccine recommendations that were voted on much earlier this year, we anticipate publication. We did add Hib vaccine as well to the adult schedule. And so the ACIP members should have a copy in their notebooks of the schedule, and the red arrows just note where these changes are in the schedule this year. So again, moving PCV 13 and PPSV 23 and adding Hib. So this is figure 1, which is by age group. And then we have figure 2, which is based on health conditions. And so for Hib, again, consistent with the language already voted on by the ACIP, we do note for the immune compromising conditions column that the only group for whom this vaccine is recommended who has potentially received Hib before are patients post-stem cell transplant, but we chose not to make a separate column given that the real estate on this figure is pretty small. There are a few updates to the footnotes as well, which I will go over in brief. And then I have, again, for the ACIP members and in the copies of the slides, the more detailed exact wording of those changes. So for influenza vaccine, information about the recombinant influenza vaccine is added, and additional language, again, about egg allergic patients was also added. For the TD and Tdap footnotes, we attempted to, as much as possible, harmonize the language between the pediatric and the adult schedule. And in doing so, what we realized was that when we went from a paragraph version of the footnotes to a bulleted version of the footnotes 2 years ago, we inadvertently left TD off of the information in the footnotes. It was always included on the figures to get TD every 10 years, but it got dropped inadvertently from the footnote. So anyway, it is now back included. The language is now almost identical to the pediatric footnote. It includes a language about TD, and we apologize for that error. For varicella vaccine, the footnote just clarifies that adults who have an immune-compromised condition born in the U.S. before 1980 may not be immune to varicella. And for the HPV language, again, this was harmonized with the pediatric schedule. And as Yabo mentioned, there have been questions about the intervals between first and second and third, and first and third doses. So this language was clarified. Again, to potentially increase or not have to further decrease the font size on the footnotes, we've removed some of the language about healthcare personnel vaccination for HPV vaccine as well as for zoster vaccine. Now that these vaccines have been out for a while, we're not getting nearly as many questions about whether healthcare workers can get these vaccines or not. And just to reiterate, for the zoster vaccine, again, remove the bullet about healthcare personnel. It's not being a specific indication for the vaccine. It already is noted with the color of the footnotes and the legend for the figures. For PCV 13 and PPSV 23, again, we just changed the order of those footnotes to make it clear that for patients who need both vaccines, that the PCV 13 should be administered first. And for the meningococcal vaccine, there are a number of suggestions, again, about how to make this footnote clearer about who needed one dose versus potentially more doses and with which vaccine. And then it also clarifies the existing recommendations that persons with HIV are not routinely recommended for the MCV4, but it does clarify that if these persons do get vaccinated, they should be getting 2 doses. And then for HIV vaccine, we updated the language per the recently approved ACIP recommendations. The contraindications table has, again, very few changes. We added information about the recombinant influenza vaccine, and then we also updated language about persons with egg allergy and influenza vaccination, and then added information about HIV vaccine to the table. So again, similar to the pediatric schedule, we'll revise the adult schedule based on discussions at this meeting today. We'll then be submitting the schedule for CDC clearance as well as review by our vaccine-specific SMEs, any of the work groups that are also impacted. And then we will also have review by our colleagues at the various professional organizations who also look at the schedule, including AAFP, ACP, American College of Obstetricians and Gynecologists, and American College of Nurse Midwives. We'll be submitting the schedule to the MMWR office and also to Annals of Internal Medicine very early in December, and we anticipate publication the first part of February. Now I'm happy to go over any of the individual footnotes. You have those in your packets. Or if you have questions right now, we can take that. Dr. Tempte, I'll defer to you.
Any discussion here or questions for Dr. Bridges? On your slide on varicella, in the footnote, I was looking at the very fine print in the additional slides here. I just wonder if this makes it a little bit confusing for people because it goes into evidence for immunity, except, if you're immunocompromised, that you may not be. And at the same time, it's contraindicated to vaccinate. I just worry that sets up kind of this internal conflict for people who are trying to use this for guidance.
That's a good point. We We actually talked about doing this footnote a couple of different ways. One would be to not say anything about immune-compromised persons in second footnote, and to have evidence of immunity to varicella in adults among whom vaccination is being considered includes any of the following. So if that was an alternative, and we can certainly go back to that language if that's clear.
Yeah, I don't know if it's just me or not, but it's these are types of questions I get occasionally, and just any clarity would be appreciated.
Sure. Yep.
Other questions? Oh, Dr. Relly.
This isn't a direct question, but a comment. I think you'll see on the graph that there is a white box for pregnancy under PCV13 as well as under HIV. And recognizing that this table does not reflect anything new and that we can't make up anything new, I would request that at a future meeting there be a specific conversation about the safety of inactivated vaccines for pregnancy. Because when there's a white box, you're left with not knowing. I think that there's the assumption that it's unsafe. And so then you have to go back and figure out, can you use this in pregnancy, can you not? There's something specifically written about HPV, we know not to use it during pregnancy, so that's white, that makes sense. Yet there's nothing specific written about PCV and HIV. And when I first looked at it, I thought, oh, well, it's unsafe. But actually, that's not what the data shows, and there's a smaller amount of data. But I think it would be very helpful just to have clarity on all of the vaccines, the inactivated vaccines that we are suggesting to be used in pregnant women, and just be very clear that if there is a recommendation to use it, that's clear, and if there is, if there's no safety data, don't use it, that's clear, because this leaves practitioners with high-risk women sort of not knowing. And my guess is that as a practitioner, I would say, oh, I would assume it's unsafe and just not use it.
That was a wonderful point. I think, is that something we can send to the pneumococcal and HIV working groups just for consideration? Again, because we would like to have more specific guidance. I think also that really pulls things into what we'd like to be doing here in conjunction with the maternal vaccination work group at NVAC. So appreciate that comment. Dr. Dushin.
Would it be useful to make the white box no recommendation, not contraindicated?
The problem with that, though, it would leave, if you're talking about pregnancy, HPV is specific, delay your HPV vaccination until after pregnancy. So that's pretty clear. You know what to do with HPV. Don't give it when she's pregnant. But my understanding is that certainly for, PCV, if you had someone who was high risk, you could give it during pregnancy.
Dr. Lair.
So when I'm looking at it, there are 6 different white boxes. 2 of them are not applicable because they're male-female discordant. One of them is not recommended, and the other 3 could be, like Jeff said, could be not recommended, not contraindicated. So you could have different answers for different white boxes.
Dr. Schuchert.
At the risk of saying something I shouldn't say, I think that this schedule is challenging, and I think we want it to be everything for everyone, but once we have a list on the left, there's a desire to sort of figure out, well, what do I need to do with that in this particular population? Another way to think about the schedule is to say, if you're caring for a person in a column, what are we recommending that you give? And we have this desire to be comprehensive and inclusive and comment on everything on the left, But the reality is there are a couple vaccines that it's important pregnant women get because they're pregnant. There are many vaccines people with, diabetes are recommended to get. And so it may be we want to think through what does the practitioner actually need to positively do as the main point of the schedule, or ideally we have on the internet a different schedule just for each of these groups where the real estate doesn't get so precious. So from my sense, in pregnancy there are a couple vaccines we're strongly recommending that we give. The number of adults in the country who really need a Hib vaccine is minuscule, but there are a lot of pregnant women. So I would want us to make sure that pregnant women are getting like the key vaccines that they need to get. So that's just my comment on the white boxes and not having them drive what the schedule in terms of positive prompt that it's meant to be.
Ms. Pellegrini.
Is it possible that we're getting hung up on the phrase no recommendation, because it sounds like this group means something very specific by that there wasn't a vote of an affirmative recommendation? It doesn't necessarily mean there isn't guidance about what to do in those cases. So maybe we could refine that wording a little bit to indicate that they should go to the footnotes, or that there may be other guidance.
Ms. Hayes?
Carol Hayes, I'm representing the American Nurses Association today and the American College of Nurse Midwives. And my experience is clinically that when vaccinating a pregnant woman, I don't even look at this. I go to the lengthy section where you go over each vaccine and why it's not recommended and why it's contraindicated. And so I think the white boxes and the purple boxes and the red boxes are the only ones that matter, really. And if we make it very clear, if you're glancing at this, you know what you shouldn't give and you know what you should give, and you should go to the rest of the real estate for the white box.
Dr. Jenkins.
I have a sort of a practical consideration which can be done online, which is it sounds like there is information and guidance on some of these vaccines, but it doesn't fit going on the schedule because there's no recommendation. We can hot link to those sections for people who use the internet to get information about the vaccines, and that might be helpful to know that there is more information that you can sort through and make your decisions about it.
And just some feedback to Dr. Riley. Back when I used to do obstetrics, I didn't pay attention at all to ACIP. I paid attention to the flow sheet from ACOG for my guidance during pregnancy. So it's just a plea for that guidance that is used not only by your members but by family docs to be proactive as well.
But we're going off of this, right? So ACOG isn't coming up with their own information. It's not so much that I'm worried about the boxes, because I'm not that worried about the boxes. I agree with you, the nurse midwife group. I mean, there's no way that we're picking this thing up and looking at it for specific pregnancy. But I just think that for those people who do, and for general docs who look at it and then tell their pregnant women, oh no, you can't have this and you can't have that, and then the OB is the person trying to sort of talk them down off of a ledge. I think where there can be clarity, that is helpful. And so what I was really, not so much a comment about this particular picture, as much as it would be very helpful if ACIP had a real comprehensive look at all of the inactivated vaccines that we now should be giving to pregnant women with real clear safety data. There's, this much in flu, and there's this much for Hib, and recognizing that Hib, in pregnant women is going to be small, but it just takes away that assumption that if there's nothing clearly out there, it's unsafe, and that gets us, because it's easy to go from Hib's unsafe to, oh gee, maybe some of the other ones are unsafe, and that's what we're trying to go against.
I had Dr. Freihofer and then Dr. Lett.
I think I'll pass. I think my comments have been made.
Dr. Lett.
I'm maybe not the most appropriate person to sort of comment on this, and I realize, clinicians that are seeing pregnant women in practice need, readily available guides, and it'd be great if everything is in the schedule, but I actually think that the CDC has a great guide for pregnancy and breastfeeding women, and I give it out all the time, and it's got a wonderful description of which vaccines have been studied, which things aren't, what their FDA ratings are, and there's an accompanying chart that you can put up on the wall that has the colors that you're I think alluding to, and a little more detailed guidance. And I think it's a great resource, and so I just am putting a plug in for it. I have it in resource slides in most of my adult vaccination talks.
Dr. Pickering.
Excuse me, one is a question, one's a suggestion. The question is, Carolyn, I imagine you're working with, I think, the 3 professional societies for content syndication for the adult schedule also?
They certainly get the information about the content syndication, yes.
And I think anyway, the liaisons or members of the committee who are in those organizations can help. I'm sure they would be willing to do that. The second question is, I just looked at the childhood schedule and there's 3 pages of footnotes, like real small type, and the adults probably will be equal to that. One of the things that we might consider for future is a follow-up on what Renee said, is that many of the things in here you probably could link electronically, and as we move next year toward maybe an only electronic version of the schedule, and everybody, when you make rounds, they all use their iPads and iPhones. Once the apps, the mobile apps are available, things like evidence of immunity, rather than listing all those things, a link could be put in there. And so I think for next year, maybe we can really look at both of the schedules and determine whether a lot of these links should be added as we gain more data as to whether or not these are used more electronically or more hard copy forms.
Dr. Freyhofer.
I think Ann's comment about the schedule and what we're trying to encourage during pregnancy is important. As has been pointed out, the contraindications are clear, but if you look at the 2 yellows, the influenza and the Tdap, that's what we're trying to do during pregnancy. And the other vaccines, I mean, it's going to require deeper insight, but I think an OBGYN's probably going to get an internist to help, and we would love to collaborate. Another point about making everything just web-based, I find this very useful to have information in the exam room in a paper form that I can actually have patients look at. So I mentioned the vaccination, I may go do something else and then come back, and then they can have their questions answered. So please don't take the paper away from us. This is really helpful. Thank you.
Oh, Dr. Lair.
Would it address the concerns if you had in the white box, not applicable, safe, but you understand that it's safe, whereas HPV in female is not recommended, so you could either have very, very small words, but they might work.
Dr. Tempe? At the, on one of the working group calls yesterday when we were discussing these boxes for pregnancy, one suggestion was that potentially it might be helpful to have a separate session at a future ACIP meeting to review the safety data on inactivated vaccines in pregnancy, and that might be helpful then to try and resolve it with the schedule.
I think it would be premature to put anything in those boxes at this point in time and keep them as they exist now. I think as the point has been made, that the real big target here is the influenza vaccine and Tdap during pregnancy, and the other, and also, you know, avoiding things that we now have a higher likelihood of danger and so on, and that's borne out here. When we start, I think, dealing with some of the nuances and the boxes in question, those are people who are at high risk for other things to begin with. And then it really becomes kind of a weighing of, if I have a person who should be getting one of those vaccines because of other contraindications and they're pregnant, it really is something between a physician, the patient, and so on. And I don't think we have sufficient evidence one way or another to give much guidance, and especially through the chart here without having further discussion. So that's my long-winded answer to you.
Just one other small thing to point out for the HPV vaccine footnote. We have said for the last several years, if a woman is found to be pregnant after initiating the vaccine series, no intervention is needed. The remainder of the 3-dose series should be delayed until completion of pregnancy. So we will offer that reassuring language for the HPV, but it's currently not in the other footnotes.
Very good. Other questions? Is there someone willing to put forth a motion for adoption of the 2014 schedule? Okay, I have an affirmation from Dr. Bennett. A second? Dr. Curran. Any further discussion? Seeing none, we will start with Dr. Bocchini and go to your left.
Oh, good. This way I won't have to just show how ignorant I am about left and right. So, okay. All right. All right. So, Bocchini, yes.
Harriman, yes.
Jenkins, yes.
Rubin, yes.
Coyne-Beasley, yes.
Vasquez, yes.
Harrison, yes.
Campus Outcalt, yes.
Pellegrini, yes.
Bennett, yes.
Tempte, yes.
Karen, yes.
Kemp, yes.
Duchin, yes.
Reingold, yes.
And unanimous approval of the 2014 adult schedule.